Thank you very much. So, I'm tasked to talk to you about dislocations and subluxations. So what I'm going to do is pass you on some of the tips, tricks and techniques that we've learned through our rehabilitation program. As you've probably gathered, we run an inpatient rehabilitation program for EDS and hypermobility in the UK. It's the only one, and as far as I'm aware, possibly the only one anywhere. I haven't come across anyone else doing this. So this is what our patients have taught us over the years. So I'm going to pass on some of those tips, tricks and techniques which I hope you should find helpful. So dislocations and subluxations happen, and they happen in the normal population as well. And here's a classic example. I think this is from Australian football, and from lots of other sporting activities as well. So dislocations happen. And not just in people. That's a rabbit with a dislocated hip. And then there's hypermobility, and that's an EDS, and that's a whole nother level. So this is different to someone who doesn't have EDS who dislocates. So that's the first thing. So the advice for someone who's not got EDS or hypermobility and dislocates, usually after trauma, is not the same as for someone who has EDS. It's different. And this is what I'm going to give you some more information about. So, to talk about hypermobility, we need to talk about the joints. And in EDS and any cause of hypermobility, whether it's EDS or other genetic conditions, the joints are more bendy than they should be. It's also really common that the proprioception, that ability to know where your joints are in space, is often pretty rubbish. And if you've been in at my other talks, I'll have asked how many of you here walk into doorways. So that dyslexia-dyspraxia link is quite strong in EDS. And if you're not very good at knowing where your joints are in space, it's going to be easier to sublux or dislocate. We know that because of the hypermobility, the ligaments and joints are not as supportive as they should do. And that means that many people can have recurrent subluxations and dislocations. But people often think that the ligaments and the joints are the main thing holding your joint together. But if you've done dissections, such as I've had to do, if you've actually dissected a joint, the ligaments and tendons are pretty pathetic. It's the main thing holding your joints together are the muscles, and it's that muscle stability and tone that's the key feature. And I'm going to explain a lot more about that to you. So as we said, it's the muscle fitness and tone that's really key to supporting your joints, and that is what is compensating for that extra bend and give because of the laxity. But pain often stops you from using the joints and the muscles the way you should do. And if you're not using the joints and the muscles normally, you're more likely to get those muscles deconditioned and weaker. They're going to get more irritable. And the more they become weaker and more unstable, it means the joint is becoming more unstable as well. So you're more prone to the subluxations and dislocations. And this is yet another of those vicious circles. Plus, the muscles are often very irritable. There's something about EDS and muscles that they're often very irritable. And that's probably because they're having to work more. Plus, the deconditioning makes that instability worse. And then I'm going to talk to you a lot more about muscle patterning, because the way that the muscles activate and coordinate isn't normal in EDS either. Normally, we don't have to think about how we move a joint. It just does it at a subconscious level. But there's something different that happens in EDS, and particularly in unstable joints. And that's something we call muscle patterning. And this is what actually drives a lot of the subluxations and dislocations. And I'm going to explain more about that to you. So around a normal joint, muscles work together in a nice, smooth, coordinated pattern. So in order to bend my elbow, my biceps muscle is activating, and that bends the elbow, but it means my triceps muscles at the back have to switch off and relax. Now, I don't have to think about that, it just does it. But in muscle patterning, this is different. So in a normal joint, everything works together, it's cooperative, you don't have to think about it, it works nice and smoothly. So your little beasties here are quite happy and they're in their little pyramid. That's not the same in an unstable joint with muscle patterning. So in this case, you've got some muscles that are on absolute overload. They are active all the time and will not switch off, whereas other muscles that should be working are doing nothing. They're on strike. And that normal smooth coordination has gone. And it's this abnormal pattern of how the muscles are working that actually physically will pull a joint out. And where we see it most is in the shoulder. So that's one of the major problematic joints. But we also see muscle patterning issues around knees and around hips. And so when you're dealing with the pain from subluxations and dislocations, you've got both the acute pain side, so this is the pain that anyone would get with a dislocation, so even a healthy person, this is the acute pain that you get from damage, as well as the background chronic pain. But then on top of that, because this is EDS we're talking about, the joints can come out easily, but they can go back more easily, provided those muscles don't go on overload. It's that muscle spasm that stops a joint from going back. And that's the key to managing subluxations and dislocations. And the more that muscle is getting tight, and the more pain you're getting, the more stress there is, the more panic is, it feeds in, and the muscles hang on more and more and more, and that joint will never go back. So the key is looking at the muscles and trying to stop this vicious cycle of pain, stress, anxiety, panic, muscle spasm just getting worse and worse and winding itself up. It's also important when I see patients early on that I've got an opportunity to explain about subluxations and dislocations. If you've got EDS, you've got noisy joints. You're not someone that's going to sneak up behind someone. They're going to hear you. But it's also important, so particularly when I see someone early, to say, hey, that's fine. That's normal for you. Your joints are noisy. You will snap, crackle, pop, and it's not necessarily a subtle one. It can be incredibly loud, and you can hear it from a mile off. But most of those snaps, cracks, and pops are not actually dislocations. So it's really important for me to be able to reassure someone who's at the beginning of their diagnosis, it's okay, you don't need to panic about these. You'll learn what's normal for you. And actually, a lot of these noises are normal for you. You don't need to panic about that. So don't be afraid of noisy joints. And above all, it's learning how to self-manage this. You do not want to be constantly going to ER or to doctors or to physiotherapists that don't believe it, don't understand what it is, or just tell you you're mad and attention-seeking. So the key is learning how to manage this yourself. Common joints, the really problematic ones, probably don't have to tell you. Shoulders, knees, and hips are probably right up there, but every other joint as well. It's also quite helpful when I see patients early on that if you have HEDS, and this is specifically on the HEDS, if the hip anatomy is normal, so this is someone that's got, when you've got x-rays, the anatomy is normal, it's a normal ball, it's a normal socket, it's fitting normally, it's incredibly rare that those joints dislocate. That's not the same if you have HEDS and have abnormal anatomy. So some people are born with dysplasias and the joints is just more shallow. That can slip out and dislocate. Fortunately, that's much, much rarer. So I'm often able to reassure HEDS patients, particularly early on, that the noises you get from hips, and it's not minor, it's like a pistol shot. These are not dislocations, they're subluxations and snapping hips, and that's really important to be able to help to reassure people. So as long as the anatomy is normal, that's incredibly rare. Now, the biggest issue is when you've got a joint that keeps coming out, and this is the recurrent dislocation and subluxation side. And in these joints, it's the muscle patterning that's really, really important, and it's often the muscle patterning that is the main driver. If it's your muscles pulling your joint out, and in the shoulder, that's classically the case, surgery cannot and will not overcome that. And I've got a slide later that I'll show you more about that. So if it's the muscles and the way they're reacting and the way they're working, pulling that joint out, no amount of surgery is going to overcome that. You have to fix the muscle patterning first. So the really important thing is to recognize and treat early. So if someone's starting to get an unstable joint and it keeps popping out, get the advice early. I don't want to see them 4 or 5 years down the line when it's going to be much, much harder to treat. It's also really important if you're starting to get an unstable joint to develop your own self-managed dislocation plan. Have a dislocation subluxation plan ready. So if you have a bad one, what are you going to do? Have it written down. Have your plan ready. It's also important that if you do have a joint that comes out, you've probably all got your own little techniques and wiggles to get it back. Now, that's usually fine. So most of the techniques that people use, the little wiggles and ways of getting it back, sometimes just a little bit of help from someone else, that's fine. What shouldn't be happening, and I have sometimes seen, is you've got a great big meaty partner who's levering a joint back in. Absolutely no, that should not be the case. So I've seen small women with big rugby playing type husbands putting huge amounts of strain trying to get hips and shoulders back in. That shouldn't be the case. If it's a minor little wiggle, your own little technique for getting it in, or just a little help from someone else to pop it back in, that's fine. But if someone's levering it back in, no, that needs to be addressed. Learn the triggers. So if you do have a subluxation or dislocation that's particularly problematic, What was it that led up to it? Is there something you can learn from it? Did you pick something up at the right angle? Did you just do something the wrong way? Learn from it so you don't end up in the same position again. And above all, frequent visits to the emergency room is definitely not the answer. I'm sure you've all been there, and the last thing you want is an emergency room doctor thinking that you're mad, they don't know what EDS is, it's in your head, or even worse, you're a drug seeker. So frequent visits to A&E is not the answer. You need to learn how to manage this yourself and try and keep out of A&E. Sorry, A&E is our acronym in the UK for the ER. Keep yourself out of the ER as much as you can. Learn how to cope and manage yourself. So in dislocation, as we've already touched on, one of the main problems with a really nasty subluxation or dislocation is the pain it causes. And that pain, if you had to sit through me with one of my other talks, you'll realize that pain automatically switches on stress pathways. It's because that's how pain is wired. It will switch on your sympathetic, autonomic, flight-fight pathway. That stress feeds into the anxiety. Some people get really quite nasty panic attacks with this. You can often find you breathing faster. And if you breathe faster, you can often find it feels shallow, as though you're not getting enough air in. If you start breathing faster and faster, you can actually get into hyperventilation. I don't know if any of you have ever experienced, if you go enough, you can start to get the tingling in the face, the tingling in the hands and the feet, and you can even get the spasm. And that's because it's tipping over into hyperventilation. And that's tied up with fast breathing alters acid balance in the blood, and that's what leads to the tingling and the spasm. So recognize that that's starting to happen. But the more the stress is, the more the pain is, the more panic it is, the more it switches on the spasm, and it causes that spasm and tension, and that is what will stop the joint from going back. So that's the bit that needs to be tackled. I had to put that up, didn't I? So here we have Boris demonstrating hypermobility and Boris. So what does a dislocation plan look like? Well, actually, it's quite simple, it's quite common sense, but it's worth just going over that if you don't have one. Number one, who's here is science fiction fans? Have you come across The Hitchhiker's Guide to the Galaxy? There are some people here. So number one, don't panic. That stress pathway is going to wind this up massively. So number one, don't panic. The joint's out. It's incredibly painful. It's understandable it's going to switch on your stress pathways. It's horrible, but it's not life-threatening, and you can manage it. So number one, don't panic. But support the joint in a comfortable position. So if you need lots of pillows, get it somewhere so it's comfortable, so you've got the best chance of being able to relax the joint. So if it's a mountain of pillows, if it's resting on someone else, get it comfortable. Breathe normally. If you start to find that breathing rate going up, slow it down, calm the breathing down, so it'll go, again, it all starts to bring down the stress pathway, so you're starting to switch off that sympathetic stress pathway. If you've got backup painkillers, this is the time to use it. So a lot of people have a sort of backup stronger medication for really bad spells. If you haven't, think about that, but have a backup medication, this is the time to use it. So if you need it, use it then. Anything you can do to relax it, do it. If that's heat, ice, cold, massage, distraction, if it means getting your other half to do a striptease, fine. Whatever it is that helps to distract, help to bring that stress pathway down, use it. Anything to start to bring this down. Above all, give it time. It's not going to go back in 5 minutes. Sometimes it might, but quite often it might not. It doesn't matter. If it needs time, give it that time. And as soon as you feel it's relaxed enough, you can probably do your little wiggle, your little trick and technique, which will just get it to go back. So give it the time, and when it's at the right point, do your wiggle, do your little technique, get it to go back. And then once it is back, you would treat it like you would any other acute injury, so any sort of other sort of traumatic injury. So you might use the rest, the ice, compression, bandaging support, elevation. But you'd be cautious about how you use that joint for the next 2 to 3 days. But what you don't want, and this is where it's different from a patient, from someone who doesn't have EDS, is you do not want this joint immobilized for weeks at a time. That's pretty disastrous if you have EDS. And I've seen too many cases of, not that long ago, someone had dislocated her knee. 6 months later, she came to me in clinic with a still full leg straight, what we call cricket pad splint on. Just disastrous. So that's where it's different from someone who's not hypermobile. So yes, you might need a splint and support for a few days, but you're not going to immobilize it for weeks on end. This is where it's different. What if it won't go back? Well, give it more time, revisit your dislocation plan. Are you as comfortable as you can be? Are you as relaxed as you can be? Is there anything else you can do just to help? Is there someone else that can help you a little bit? Like most of us don't want to ask for help, but this might be a time, if you're really struggling, that you do need someone else just to give you a little bit of help and support. Have you used your backup plan medication? So do you have sort of emergency backup plan medication that you could use? Now, obviously, sometimes there will be occasions where, unfortunately, you do need to go to the ER. And that might be if your limb goes really cold, really discoloured, really numb. You may have no choice. Sure, that might need a trip to the ER. But most of the time, you can self-manage. And the more you can keep yourself out of ER, the better. If you do have to go to the ER, do they know you have EDS? Now, that doesn't guarantee they know anything about it, but at least they know you have EDS. If you've got to the ER, by the time you got there, has it already gone back? It's a really common story I hear, that people have been struggling and struggling and struggling with the knee or the hip or the shoulder, and then by the time they get to ER, it's already gone back. But at least that's telling you that given a little bit more time, it will go back. If you're a regular visitor to the ER, do you have an ER plan? What you do not want to be defined yourself is labeled as a drug seeker. So if you've got a really unstable joint and you're having multiple trips to the ER, you need a plan with them so they know who you are and they know why you have the problem and they can sort you out properly. For instance, you don't need multiple x-rays. So if you know you have an unstable joint, there's been an x-ray in the past, it shows it's out, you don't need to keep having an x-ray every time you go to the ER. And that's a problem we see in the UK as well, trying to persuade an emergency room doctor, no, I don't need an x-ray, I just need help to get it back. You don't want that unnecessary x-ray exposure. So you may need an emergency room plan. You want to try and keep the medication as minimal as you can, so you've got backup medication, but you don't want to be someone who's on a huge amount of medication because you've got lots of subluxations, dislocations. And the best example I can give you for that is there are some incredibly strong medications which I've put here under caution. Now, if you have a problematic joint that might need an emergency room visit once every couple of months, I'm not going to worry too much. But I have patients, and I've spoken to someone earlier, whose joints are coming out 3, 4, 5 times a day, who are going to the ER 5 times a week. 3 times a week. Now, obviously, if you're going to the ER 3 times a week, and every time you go, they're filling you full of high-strength opiates, high-strength benzodiazepines, you're going to hit problems really quickly with drugs. So that's why it's really important to get this under control. Now, I've put caution here, and this is because sometimes doctors try to help you, but actually it can be a disaster because they don't know about the EDS. There are horrible things called fentanyl lozenges. Now, I think they're relatively rare in the US, but I know you have them. We have them in the UK. You've probably heard of fentanyl, probably the most powerful opiate medication we have. A fentanyl lozenge is a lollipop on a stick with fentanyl in it. Can you think of a better way to get an addiction? I can't. They should only be used for cancer pain or for severe post-operative pain. But I have seen cases where doctors are trying to be helpful and say, oh, this person's in really bad pain, they get these dislocations, here, have a fentanyl lollipop, then you'll be able to get it back. Not realizing that that's happening 5 times a day. And I've heard a fantastic presentation some years ago, actually in the US, from a patient who had a horrendous fentanyl lozenge addiction and wrote a book about how she overcame it. So fentanyl lozenges, don't go there. There's an equivalent with a buccal tablet of fentanyl, so it's a high-strength fentanyl tablet that you put between the thumb and the cheek, same problem. That should not be used in this sort of problem. That's something used for cancer pain and for post-operative pain. It is not appropriate for this sort of thing. The other one I've mentioned here, and that's because most of my pain colleagues don't know this, is that gas and air, that's nitrous oxide. In the UK, you can actually just buy it. You don't need a prescription. You can just go out and get it. You can buy the tank, you can buy the breathing tube, and you can go out and get it and use it at home. However, what a lot of people don't know, it's addictive. And it has another problem in that if you have a lot of exposure to it, it wipes out your B12. And we have had cases at Stanmore with unstable shoulders where patients have been on so much of this gas and air that they've wiped out their B12, and then you can get a neurological condition called subacute combined degeneration of the cord. So there's a caution with nitrous oxide. Used occasionally, not worried. But someone using it for a couple of hours a day, every day at home, you're going to hit problems. So what about orthopedics and shoulders? Well, when an orthopedic sees you, because you've got an atraumatic, it's what they call atraumatic shoulder instability. So this is where you have a shoulder that falls out, but you haven't had trauma that's caused that. In a healthy person, if you have trauma, like we saw that footballer, and you've got a shoulder come out, because you can have the damage, in a healthy person, it can keep coming out. But that's a different reason as to what's happening in EDS. So the first thing they'll look for is the anatomy normal? Or actually, is the anatomy not good? So some of us are born with better shoulder joints than others. So one of the things the orthopedic surgeon will look for is the anatomy fairly normal, or actually is the anatomy abnormal? Sometimes if you've had a lot of dislocations, you can start to get damage in the joint as well, so they'll look for that. They'll look to see is the capsule loose. Sometimes you can get very baggy capsules, and just occasionally surgeons will do things like try to tighten up a capsule, but again, even that has to be approached with extreme caution. Rotator cuff muscles and tendons, they will also look at that. Are those intact? Do you have tears? They will also look at things like the ligaments. And what should happen, but often doesn't, and that's because they're not aware, is there muscle patterning? Because if you're in someone who has atraumatic shoulder instability, an EDS, and relatively normal anatomy, it's usually the muscle patterning that is pulling that shoulder out. And doing orthopedic surgery in these cases is often pretty disastrous. Plus, there's the problem that if a surgeon isn't aware of EDS and tries to tighten things up, it's like tying knots in an elastic band. It's still elastic, and that's why there's a very high failure rate. So the main focus, if you have the muscle patterning, is on the muscles. Surgery cannot overcome that, and I've got a little slide further on to show you about that. So it means I can also introduce you to the Stanmore Triangle, and that's actually named after the establishment where I'm working. So it's a centre of excellence nationally and internationally for the unstable shoulder. And this is called the Stanmore Triangle. If you've got a switched-on shoulder surgeon, they should be aware of this. Now, what it's done is it classifies shoulder instability into 3 types. So type 1 is someone that you might see who doesn't have EDS, has had trauma, that shoulder has come out, and now it's unstable. So that's type 1. Type 2 is where there hasn't been trauma, the shoulder's coming out, but the shoulder isn't structurally normal either. Type 3 is where it's falling out, there isn't any trauma, but structurally it's normal. And in these cases, it's the muscle patterning almost certainly that's pulling it out. Now, most cases of EDS with unstable shoulders are type 2, type 3 on the Stanmore Triangle. So with an unstable joint, the first thing is optimize the non-surgical treatments. Surgery to fix unstable joints rarely works. I don't say never. Everyone's an individual, and occasionally the right surgeon and the right operation can be helpful, but it needs to be someone that knows what they're doing, and it needs to be someone that's appreciative of what EDS is. So surgery needs to be approached with caution. There is a high failure rate, and if the muscle patterning isn't addressed, the surgery is never going to work. You need to ask your surgeon, what is the potential of being worse off? Because if there is potential for that. And I always advise extreme caution with fusing joints. The trouble is, if you fuse a joint, it means the joints above it and below it have to compensate and work harder. So if you've already got unstable joints, you're now making the ones above and below it even more unstable and having to work harder. And I have seen some complete disasters with fusing joints. So that needs to be approached very cautiously. Now, most hypermobile EDS recurrent shoulder dislocators are, as we said, type 2, type 3 on that Stanmore Triangle. And in these cases, it's typically the muscle patterning that's pulling it out. Now, the commonest pattern you see, there are lots of patterns, but the commonest one is the pectoral muscles at the front are working too hard and pulling it out at the front, and the shoulder blade stabilizers at the back are not working at all. And that's often why the shoulder blades stick out, and it's that patterning that needs to be approached. This example is that in extremely rare cases where there is extreme shoulder instability, and I know there was someone in my previous session that this applied to, but it fortunately is very rare, occasionally shoulders are fused. Now, this is irreversible, And basically what you do is fuse the shoulder to the shoulder blade, and then you have a shoulder that cannot come out of joint, but you can't move it either. So the only movement you will have is here. You are completely fused, and that is irreversible. Now, sometimes if that's being considered, because it's such drastic surgery, you can do something called a Steinmann pin, where you basically put a great big metal pin, a bit like a knitting needle, stick it straight through the top of the shoulder bone into the shoulder blade, and it completely fixes that shoulder. And then you leave it there for a couple of weeks so someone can actually understand what it's like living with a fused shoulder. And quite often patients will then realize, whoa, I can't deal with this, but it's a reversible procedure. You then take the pin out. However, in muscle patners, where it's the muscles pulling it out, within 24 hours, it's pulled the pin out. That is how strong this muscle patterning is, and that is why surgery will not overcome it. And that's a picture there of a migrated Steinmann pin, that other picture there. So exercise and physio, unfortunately, is the main key to improve muscle stability in unstable joints. Not like that, though I hasten to add. Then what does the dislocation plan look like? Well, it's absolute basic. It looks like this. Number 1, don't panic. Number 2, breathe. Slow the breathing down. Number 3, stay calm. That's your basic dislocation plan. Now, and the same plan for subluxations. Now, you may build other bits around it that works for you as an individual, but that's the basis template for you of a dislocation plan. And I'm going to leave it there and offer it open to questions. Thank you.
Okay, so some of you have already submitted some questions on the app. That's probably going to be the best way. I'm going to try to group these into patterns. So there's been a couple questions related to subluxations and dislocations when the person also has CRPS.
Oh, right, okay.
And is there a higher risk that the CRPS will spread?
Fortunately, a lot of the time, no. As I say, CRPS spread, fortunately, is actually very rare. You wouldn't get that from reading a lot of the websites. There's some good information out there for CRPS, but some really bad information as well. And some of these websites, if you read it, you'd think if you've got CRPS, you're going to spread to all your limbs and you'll be in a wheelchair. Fortunately, the evidence shows us that CRPS spread is actually very rare. If it does happen, it's usually because there's been a new trauma to a new limb. So if you have a shoulder or a sort of joint that's unstable, provided you're managing that, I wouldn't necessarily expect that to create new CRPS. It's not impossible, but it's actually quite rare. More often what we see is that because CRPS, although it happens usually in one area, people rarely have just CRPS. As we've just described in some of my previous talks, if you've got that severity of pain, it winds up your whole pain system. So more often what we see in CRPS is you've still got the CRPS, but you've got a completely wound up pain system, and that aggravates pain in other places, and it's that more often than actually spread of CRPS.
That's good. Another series of questions relate to rib subluxations and dislocations. So there's probably about 10 of those comments.
Absolutely, yeah. This came up when I did the talk earlier as well. The first thing I could say was, yes, it's real. I think that's the first thing, is to say, yes, we acknowledge it. I'm afraid if you ask a lot of doctors, they'll say, you're nuts, of course you can't dislocate and sublux ribs, but yes, absolutely you can. They are really difficult and problematic to treat, but I don't have to tell you that, that's why you're here. General advice is, again, you need to find your own little technique that helps to get it back. And again, you'll all vary as to how that happens. The other main advice is with ribs, it's often posture that feeds massively into rib subluxations, dislocations. The commonest place is at the bottom of your rib margins here. And at the bottom of the rib margins here, this is where a lot of your core muscles that come from the pelvis right up to the ribs, this is where they're running. And this is why posture sometimes is a big thing feeding into rib subluxations, dislocations. So if you spend a lot of time on keyboards leaning forward, or your posture's not great, that is going to make rib subluxations and dislocations worse. And sometimes the right stretches, the right exercise, the right advice from a physio to keep you stretched out and moving there and stop you getting too tight, that can sometimes help. Some people use taping techniques just to give some support. Some people will use soft supports, not solid supports, soft supports that might be helpful. But there aren't particularly easy answers and fixes. I wish I could tell you there aren't. You often need to experiment and work out what works best for yourself. Not specifically, but if you've got gastrointestinal pain, I haven't touched on that. If you have visceral pain, which is what it's called, that's the fancy name for when organs cause pain, that can actually link to body pain, somatic pain, and one can wind the other up. So if you've got gastro problems that are particularly bad, it can feed back and make musculoskeletal pain worse. So indirectly, yes, it could contribute. But at a simple level, not so much, but indirectly through some of these pain mechanisms, yes, quite possible.
Next question, there's quite a few on this, is do you have or are you aware of any plans to create a manual for patterns for physical therapists or for patients to teach techniques in how to realign joints again? I know that there are lots of groups that are approaching this, but as plans to make an overall manual, no, I'm not aware of that. Maybe that's something we should put to the society. There are a few key physios that are real experts in the EDS world. Jane Simmons, one of my UK colleagues, is a good example. And they've published a lot of papers on, for other physiotherapists on how to approach physiotherapy in the EDS patient. And certainly in the UK, they do a lot of education programs as well, and I've often spoke at those. So there's a big drive to try and educate and interest other physiotherapists. Then there are different people that have produced their particular approach to it. So I know Kevin Muldowney's been speaking. I wish I'd heard him, but I know he's been speaking and I've seen his book. So there are different approaches, but I'm not aware of a sort of grand manual design at the moment. Another question that came up a couple times, do dislocation plans work well for kids too?
Yeah, absolutely. Yeah. And again, it's about getting kids to understand what's going on. I think half the key is if you know what's going on and you know how to fight it, that takes a lot of the panic away. When you don't know what's happening and you don't know why, that is a massive driver to the problem. So yes, if kids are getting it, absolutely, educate them early. Get them to understand this is normal for them. Get them to understand how to be able to get the control back. And if they're getting the control back, that's going to empower them as well. They're not going to feel so afraid of their body. You need them to feel in charge of their body and not that their body is completely controlling them. So yeah, absolutely.
I was going to say, I spent 18 years in pediatrics, and there's a lot of times when kids get things quicker than their parents do. So yeah, give your kids credit for being able to do that. Another question that's come up a few times is, how do you tell if a joint is subluxating, and can that cause swelling of the joint?
This was asked previously as well. How do you tell if it's a subluxation or a dislocation? Sometimes it's really difficult to know. And sometimes knowing isn't going to help anyway. As long as you have a plan that works for you, it actually doesn't matter if it's a dislocation or a subluxation. As long as you can control it and as long as you can get it back yourself, it probably doesn't matter. Can a subluxation or a dislocation cause some swelling afterwards? Yes, it's almost like an acute injury, but that swelling should be like an acute injury. It might be there for a day or so, but it shouldn't last much longer and it should go down. It should be minor, it shouldn't be huge. If you've got huge swelling, that's different. You should see somebody.
Okay, next question. How do we address the muscle patterning issue? Physical therapy, massage, strength, or stretch training?
I would say all of the above and more. It's finding a way to make it work. But the key is often a good physio who's actually heard of this and knows how to approach it. The other major tip I can give you is people often give you exercises for a particular muscle. But because that ability to know what your muscles are doing and how to switch them on isn't as good, and particularly in patterning, you can often give someone an exercise for, say, their shoulder blade, and they'll switch on every muscle except the one that you're supposed to be switching on for that exercise. And that's when you need a really switched on physio who is checking that when you're doing that exercise, are you actually recruiting the right muscle? And if you're not, that needs to be changed and modified until you are recruiting the right muscle. And that's quite a common problem. And we see it in physio for shoulders, for hips, and for knees. So if you're struggling and it's not working, get someone to check, are you actually switching on the right muscle? Or has your brain still not got it? And you need other help to try and figure out how to retrain your brain so you are switching on the right muscle.
Okay, this is kind of a two-part question. How do you know when someone has a dislocation?
Part 2 is, as a care person for someone with EDS along with autism who isn't verbal enough to say where it is and hurts, how do you know what to look for?
That is a really tricky one. So it depends on your definition of a dislocation. So there are medical definitions, and that isn't the same as chiropractors and osteopaths use. That's another useful tip to pass on. We use the same terminology, but we mean different things. So osteopaths and chiropractors will often talk about dislocations, subluxations in the spine, and if you say that to a doctor, they'll probably tell you you're nuts. And it's not. It's because how we use the language is different. We would not call that a subluxation or dislocation. We would think of it as a micro problem, not an overall big problem. So number one is the terminology. A dislocation to a doctor like myself, or a rheumatologist and orthopedic surgeon, means the joint is completely displaced, it's completely out of joint. A subluxation is where it's half in, half out, it's just not quite fully in joint. In autism, and particularly nonverbal, that is really difficult, and I think it's going to be experience in learning to know between the carer and the child or the adult what is normal and not for them. It's almost more like a veterinary approach then. You have to get to know the person and to know their nonverbal cues for when it's not right. You will hopefully also learn over time, because in cases like that, you've almost certainly will have to end up at an emergency room. So you'll know that if it was dislocated, then you'll know what the signs and how they were verbalizing versus when it hasn't. So you almost have to learn with experience and really pick up on the non-verbal cues. That's much, much harder and much more specialist.
Great. Okay, here's another one. If you have a sort of dislocation when they are usually only reducible by a rugby-playing partner, this is written by someone from the UK, I can tell by the question, would you recommend them relocating it or going to an A&E?
I'd recommend learning how to relocate it without needing the full weight of your rugby playing partner. So you don't want the multiple A&E trips, but you do need to learn how to put it back that you're not needing that amount of leverage on the joint. And that's where you need a good physiotherapist to guide that. So it's that balance. No, I wouldn't want to see someone going to A&E all the time, but equally you need to learn how to put it back that you're not needing the weight through, because that's not working. That means you haven't got the relaxation right. You need to get that relaxation more so that it will slip in easily and you're not having someone lever it back in. If you're levering it back in with a lot of weight, that's when you can get damage, and that's what you don't want to do.
Is there a role then for like muscle relaxants during that acute phase when you're trying to counteract that patterning?
Cautiously, if you were at my previous talk, just occasionally. It depends how often this is happening. If it's a rare occurrence, something happening once or twice a month or even less frequently than that, then a backup medication might include something like a low dose of diazepam. It might include a low dose of a stronger painkiller, and that's part of your dislocation plan. And if that little bit of diazepam together with the painkiller gives you that extra relaxation so that then you can get the wriggle and get it back, that's reasonable. But if it's happening 5-6 times a day, no, because you'd be on huge amounts of diazepam and opiates, and that's not where you want to go. So like everything, it's a bit of a balance.
So there's several questions, and asking about the inpatient unit that you have, and is there something available like that in the US?
Unfortunately, I'm not aware of anything like that in the US. I'm hoping that somewhere a US colleague's going to come up to me and say, hey, we do that as well, but I haven't heard of any yet.
Can you explain what it is for those of us from the US?
Okay. We have a program which is a modified pain management program. And I've also discovered, talking to some of you guys here today, a pain management program is not a pain clinic which talks about drugs and injections and blocks. That's not a pain management program. A pain management program is something that aims to teach you non-drug ways of coping with pain that's there all the time. So it will often look at physiotherapy not in one bit, but as a whole. It will bring in a lot of techniques like pacing, relaxation, sleep hygiene, relaxation, breathing techniques, meditation. It'll bring in a whole range of techniques, often CBT as well. So it's everything except the pills. That's what a proper pain management program is. Now, what we've done at Stanmore, which has run pain management programs for many years, and the idea of a pain management program is it doesn't matter what the cause of pain is. If you have pain all the time and it's severe, you would do a pain management program. What we've done is modify a pain management program, so you still get all of that advice, which is essential and which is helpful, but we've added the extra bit for EDS, which is giving the education information on the EDS aspects, but also the specifics of the therapy for the ED aspects. So you're going to need that extra advice about the subluxations, the dislocations, the POTS, etc. So we've just brought in the extra for the EDS. So it's a modified pain management program. Ours is an inpatient program. Now, that's relatively rare in the UK. I think there's only 7 centres I'm aware of in the UK that run inpatient pain management programs. It's much more common to have an outpatient-based one. And typically, that will look like you attend one day a week, a full day, over 6 to 7 weeks, and they give you the same sort of information and advice, but just not at quite such an intense level. That's a relatively more common one. If you want to know more about what a pain management program should look like, what the multidisciplinary team should look like, look at the British Pain Society website. They have a great information leaflet on there about what pain management programs should look like, who the personnel should be, how intense they should be. There's lots of information about what it should look like.
Okay, that's a great answer. I actually come from a facility that we have an outpatient pain management program. It's 4 weeks long. It's about 8 hours a day, 5 days a week.
Brilliant.
But focus on physical therapy, off pain medication, but it's phenomenal. So that's in Nebraska, so. Come see me and I can give you all the contact information. I think we have time for one more question. This is kind of a loaded question, but I think it's a good one. Can you give an example of appropriate emergency medicine to have on hand for a child or teenager?
Oh,
during a subluxation.
Tricky. Typically, the sort of stuff we'd have on the UK is probably going to be a codeine paracetamol combination. It's going to be something fairly low dose. It's not going to be an opiate. It's not going to be a morphine type thing. If it's going to be something, it's likely to be a lower strength, something like a codeine paracetamol combination. Depending on how bad it is, there may or may not be a tiny amount of a muscle relaxant in there. And for some people, it may be that paracetamol and distraction is enough. You may not need more than that. So a lot of it is, again, getting the education in, making sure the child or the teenager or the adolescent understands what's happening so you don't get that panic, that they can get the control back. And quite often, you don't need the heavy medication. So again, it's that balance. You do not want to be on heavy-duty medication all the time, but you may need a backup of something that's reasonable if you need to use it. And it's probably a little bit different here, but it would be a moderate level, a weak level opioid, plus or minus an anti-inflammatory, plus or minus aminoacetafen. It's probably more going to be at that level. It certainly shouldn't be the fentanyls, the oxycodons, the morphines, etc.
Well, thank you so much for a wonderful session. I do want to ask everybody, we need to kind of clear out of this room so they can set up for the banquet tonight. So if you do have questions and you have time, we can do it in the hallway out in the lobby. Thank you so much, everybody.